And what's really weird, okay, here it is. I thought I lost everything. Welcome everyone to our, I think it's probably our fifth in our webinar series that the Solve ME/CFS initiative has given in 2014. Today we are very excited to have Dr. Peter Rowe of Johns Hopkins with us today to talk about his research on neuromuscular strain in ME/CFS. This is a project that the Solve ME/CFS initiative funded in our 2011-2012 funding opportunity. Before I go much further, the voice that you hear behind the curtain over here on the other side of your computer screens is Suzanne Vernon. I am the scientific director of the Solve ME/CFS initiative. You might see on your participant list, on the attendee list, if you see anything up there, to Lee Reynolds, and it's because of some of the quirks in our system right now. So anyway, that's one of the little oddities about this particular format that we're using. So without further ado, I'd like to have Dr. Rowe say something so that we hear your voice and jump right into this exciting presentation for today.
Well, great. Thank you, Suzanne, and thank you, Lee, for helping set everything up technically. I'm going to talk today about this area of neuromuscular strain in patients with ME/CFS, and I wanted to start with a story of how we got involved in this. It was about a decade ago, maybe a little bit over that I had a patient come into the clinic, and as it was somewhat of a serendipitous introduction to a very talented physical therapist, a real master of that craft, Rick Violand, who's a physical therapist in the Baltimore area. So the way this unfolded was that this girl came in to see me. She was 17, had been fainting a fair number of times, had all of the classic features of ME/CFS, including a couple of days of worsening of all of her symptoms after a relatively active day for her. So she was really struggling quite a bit. And she didn't do well with a standing test that we did in the clinic, so I thought she really needed to be treated for her orthostatic intolerance. And but she was reluctant to try any of the medications that we were proposing, and she wanted to just begin with extra salt and fluids. And I thought, well, you're welcome to do that, but I thought you're going to be begging me for medication in about 3 months. So I thought it's her choice, her decision. And as they were leaving, the mother had her hand on the doorknob and said, hey, what do you think about physical therapy for this illness? And I said, you know, at that time, and it was maybe the late 90s, around 2000, we had pretty poor experience with the standard kinds of exercise-based physical therapy for our patients. And typically what would happen would be that a very inactive, deconditioned patient who'd been sick for a while would go into the physical therapy office. The therapist would say, gosh, this person's really out of shape. I've got to get them in shape. And would start into a kind of physical boot camp that was just too much exercise too soon. So the patient would say, gosh, this guy's killing me. What the heck? I'm really worse off with this thing you've referred me to. And the therapist would call me and say, this kid's not willing to try. They just don't come in for all the appointments. And it ended up being a very unproductive process. People were well-intentioned on both sides, but it just didn't work. And so this girl's mother said to me, well, the guy I see, who is Rick Violand, he does things a bit differently. He does a lot more manual, hands-on therapy and manipulation. And so I thought, well, you know, let's see if it works. So back came this girl 3 months later, and I was fully expecting her to ask me for the medications that we were using at the time. And much to my surprise, she was really substantially better. It hadn't happened immediately, but it had happened gradually over the time Rick had been treating her. And I was really pretty impressed by this because we usually don't see people getting better spontaneously at that pace. So fortunately, the family and Rick were willing to meet again. Rick came in to show me what he had been doing to treat this girl. And one of the procedures he used was a maneuver where he had her lying flat on the table and was putting a strain on her median nerve in the arm. And as he put further and further strain on the arm, she became lightheaded and actually said that her vision was dimming. And those jumped out at me because those are typically the symptoms we would see as people were about to faint when they were on a tilt table. And I'd never seen anyone recreate these symptoms in a patient with the patient lying flat. So that was immediately something of interest to me because I thought these two things have to be connected in some fashion. And so Rick and I have spent the last 10 to 15 years thinking about these issues. He's been treating a number of our patients, and we find that the interaction between the orthostatic treatments and the neuromuscular strain treatments has been very productive for our patients. But we've also tried to make these observations a bit more formalized. And so I want to share some of that with you today, beginning with the initial observations we made clinically, how we've tried to hypothesize that these biomechanical factors influence and play a role in the generation of CFS symptoms, and then I'll talk, as Suzanne mentioned, about some of the research. So one of the early things we noticed in the clinical care of adolescents with CFS was that they had an increased prevalence of postural abnormalities and movement restrictions. So what do I mean by that? Well, this was an exaggerated but fairly common posture we see in the clinic. Notice that this young man has a very head-forward position. His head is not balanced on the spinal column, which is the most ergonomically effective way. So there's a biomechanical problem there that you can replicate yourselves if right now you try and stick your head forward. And I think if you do that while you're sitting in your chair, you'll feel a bit of tension and strain in the area at the back of the neck. The other thing you see in this image is somebody's not muted there, I think, is an exaggerated thoracic kyphosis, this rounding of the spine here, and a lot of our patients also have an exaggerated lumbar curve, lumbar lordosis. So that was one of the things we'd seen fairly commonly.
Muted.
The movement restrictions are illustrated in the next couple of slides. Here's what a healthy individual should be able to do with bending their ankle backwards or ankle dorsiflexion. And here's one of our CFS patients who could not even get her ankle to the vertical position. And if you think about it, if you can't bend your ankle, if you can't dorsiflex at least a little bit, you can't really get any momentum for moving forward with your stride. So this individual, in order to get forward movement, was putting a lot of strain on the nerves and soft tissues of the leg and probably all the way up to the hip. So loading the system. Another abnormality we see fairly frequently is the limitation in straight leg raising in our chronic fatigue patients. So here's the kind of range of motion you'd expect in an adolescent who's healthy. Here's about a 60-degree level of passive straight leg raise. And here's one of our patients with only about 30 degrees of straight leg raise before the onset of stretch. So that tightness is something that drew our attention. And here's another example of the kind of prone knee bend that you should be able to achieve. And here's one of our CFS patients. Couldn't even bring the knee to the 90-degree point. So along with that, we were seeing problems with the
Unmuted.
reduce CFS symptoms when we would selectively place mechanical tension on the nerve tissues. And I had mentioned that in the story about how we got this started, but here's an example of what we found later. I'll show you that slide in a second, but leading up to that, we were often hearing from patients as we were sending more of them to Mr. Violan, that after the first assessment in physical therapy, they would call me and say, gosh, am I supposed to be this wiped out? Is this going to happen each time I'm treated? At that point, we started to realize that the initial assessment often provoked some symptoms, and then the treatments gradually made them much more tolerant of not only the treatments, but of exercise in general. We didn't know what was happening during the assessment session to aggravate symptoms, but we were pretty tuned into the possibility that it could be related to the autonomic nervous system dysfunction. So we wondered whether when they were doing their assessments, the physical therapists were creating some hypotension or tachycardia, fast heart rate. So we brought in, yeah.
We've had a couple of questions about whether or not these postural abnormalities and movement restrictions are also seen in adults.
Yes, we think they're very common in the adults as well. They may be, nobody's compared the adults versus the adolescents, and it could be that as people age and they get a bit stiffer, they aren't going to have as many of the hypermobile changes of the spine, but the range of motion abnormalities are also there in the adults.
Okay, thank you.
Yeah. So what we did for the next step
Muted.
to create this was we brought in two young college-age patients, both of whom were well enough to attend college, but with lots of symptoms day to day. And this is a pretty busy slide. Ignore the colored graphics, and I'll just show you what we did. We asked them to rate a variety of symptoms on a 0 to 10 scale, pretty familiar to most patients, 10 being the worst you could get. And then to see what was going on while we placed them in a position of neuromuscular strain, we raised their leg to 10 degrees. So we were holding their leg. They weren't doing anything in terms of active work. And we gave them 2 minutes, and then we measured heart rate, blood pressure, pulse oximeter, skin temperature, a variety of things. And then we moved their leg up to the 20-degree point, let it equilibrate, and then at the 2-minute point, asked them about their symptoms, checked the blood pressure and heart rate, and so on. And we went 2 minutes at each stage up to the 60-minute point, or 60-degree point. And at that point, that was a 12-minute time point, and we then put the leg down to 0 degrees. So then if you notice what happened with symptoms, they started off, this one individual started off with a fatigue level of 5.5 out of 10. The lightheadedness was at a 4 out of 10 level, as was the cognitive fogginess. And as we raised the leg a bit, by 20 degrees, he had visual blurring. The lightheadedness was a bit worse, fatigue was a bit worse, and it got progressively worse throughout the straight leg raise strain. What was really interesting to us is that not only did the fatigue increase during the time that we had the leg elevated, but both individuals had almost identical responses, and they needed about an hour afterwards to remain on the examining table, eating saltines and drinking Gatorade before they felt comfortable enough to get up and drive themselves home. So this was a really profound exacerbation in all of their typical CFS symptoms, and we thought this has got to be really important in the overall pathogenesis of symptoms. Notice that the cognitive fogginess got worse, and it stayed bad after we dropped the leg down. Sorry, my phone's the lightheadedness increased to a 5 out of 10 point while the leg was elevated, even though with raising the leg you'd expect lightheadedness to improve. The visual blurring was impressive. The other thing I'd say about the cognitive fogginess is by about the halfway point, both college students were having trouble answering our question, how would you rate your fatigue now? And you'd get a response like, what? And very different than their pre-test situation. So this was a very interesting result. It helped us understand things a bit better, but we didn't see any changes in heart rate, blood pressure, or pulse oximetry to explain it. So what might have caused the increase in symptoms? Well, we then looked at the big literature on in modern physical therapy on concepts of adverse neural tension, neurodynamic dysfunction, and neural tension dysfunction. So I want to explain a bit of what that's all about. The general concept is that as we move around in daily life, we have to move through fairly large arcs of motion without putting so much strain on our nerves and spinal cord that we cause pain and other symptoms to develop. So the nervous system has to be able to move as the bones and the muscles move, and they have to be able to function without compromise. Neurodynamics refers to this interaction of nerve mechanics, nerve movement, and the way the nerve is behaving physiologically. So as you move, the nerves have to elongate, they have to slide, they have to create angles around the joints, and they sometimes will undergo a bit of compression. And that mechanical stress then can provoke physiologic changes, including a change in the nerve blood flow, the conduction of the electrical impulses along the nerve, and other events. And this isn't really new. You know, in medicine, we've used these principles as one of our earliest tests of the likelihood of meningitis. For example, when I was early in my training, and this was before the Hib vaccines and the meningococcal vaccines, one of the things you do in a febrile child to test whether they might have meningitis was do a straight leg raise, just like we did in these boys, but very briefly. And if they had meningitis and irritation, that straight leg raising would put some traction on the nerve roots and the dural membrane that surrounds the spinal cord, and that would result in neck pain. So these concepts in physical therapy have been an extension of some of these earlier maneuvers that are used. Neurodynamic dysfunction is the term for when you've got too much tension or strain in the nerve. Some of what we've learned from early neuroanatomic studies of cadaver dissections where they've looked at how much movement there is in the nervous system, these have emphasized that the body has to adapt pretty mechanically as we move in a much bigger degree than we had thought before. So for example, if you look at the whole vertebral, the spinal canal, when you move from full backward bending or extension to full forward bending or flexion, the canal length has to go up 5 to 9 centimeters. In the peripheral nervous system, the median nerve has to adapt about 20% in terms of lengthening between the position of arm flexion and extension, and I'll show you some of that in a bit. Alf Grieg, who is a Scandinavian neurosurgeon, had done a lot of the early work on this, and this is a slide taken from his book on adverse mechanical tension in the central nervous system, published in 1978. And what he's done is, if you see, here's the front part of the skull base, and here's the occipital bone. And he's taken two x-rays and superimposed them. The one in white is the person with backward neck bend. The one in the gray is somebody in full forward flexion. And what he's illustrating is that if you look at the distance along this arc, it's way shorter than the distance along this arc. So that's illustrating a 3 centimeter change in the canal in the length that the spinal cord must elongate. And if you think back to gym class when you're running around the track, the position you'd want to take is on the closest side to the inside of the track. So The point with regard to the spinal cord is that in the part that's at the posterior aspect of the spinal cord when you're in extension, there's less strain being delivered there than there is to the front part. Again, more distance to travel in the front part. Another way of looking at that came from one of his cadaver dissections, and here's a cadaver in panel A on this side here, where you're looking at the spinal cord and the nerve roots coming out. And what he's showing is this is the person in extension, and the same cadaver is put in a position of flexion, and you can see that all of these nerve roots are tighter, and you've lost all the slack in the system. So here it is slackened in a position of extension, tightened up in a position of flexion. And so if you can't make those adjustments as you move, you're going to have excessive strain in the nervous system and probably symptoms as a result. Another way of looking at that notion of strain is if you think about putting a longitudinal strain on a nerve, it's a bit like those Chinese finger puzzles that we played with as kids. If you pull that nerve out, you're going to get compression in the middle part of the nerve. There's just no other way around it. So you get the tensile strength longitudinally creates some tightness or narrowing in the middle section. And among the consequences you can get with that are that if that's severe, you can get some reduction in the blood flow to the nerve, so all of the needs for oxygen that the nerve would have would be compromised potentially. Experimental studies have shown that if you put excessive strain on the nerve, that it will interfere with the electrical conduction properties of that nerve, and you can get some intraneural or within the nerve edema or swelling. Others have shown that you can also get signs of the release of inflammatory neuropeptides when strain is too great. What we can see when we're examining patients is that their muscles are often held in tension, because when you go to extend your arm, if your nerve is being strained too much, your muscles develop a kind of protective tightening, and that is meant to stop you from straining your nerve further, but one of the consequences is that it makes the metabolic task of extending your arm greater. That is, you have to put in more energy expenditure to do a simple activity. And if it's a repetitive activity like walking multiple times a day, thousands of steps a day, that's going to add up and potentially contribute to fatigue. Another way that you can see this abnormal tension in the nervous system causing problems is other parts of the nervous system get really sensitized. And people have shown a number of changes in the autonomic nervous system's response, including sweating and abnormal blood flow to the peripheral tissues. So I wanted to show you on a practical level how this might play out. And I just, Suzanne warned me that we probably ought to wait until after the webinar to try this if you have chronic fatigue syndrome, because if we make you foggy, you're not going to hear the rest of the show. So if you're otherwise healthy, you may want to try this. But this is the idea of an adverse amount of tension in the nervous system that we all have to some extent. So here's somebody, my wife volunteered to be the model for this section, but she's holding her arm up in a position where the median nerve, which runs along this side of the arm, is slackened. Remember I said earlier that the median nerve has to elongate about 20% of its length to get from here to fully arm extended. So as she then moves her arm out, if you do this while you're sitting at home watching this, I can't see what the responses are, but I'm guessing that those of you who have tried this are feeling some tightness or tension in here, in the antecubital fossa. And the idea is that the nerves don't have an infinite capacity to elongate. Then if you move your neck to the side of the tension, most of us will realize that there's a bit of a reduction in that strain in the elbow here because you've fed some slack into a tight system. If you want to make everything worse, you can put your head over to the other side. And as I do that, I'm feeling way more strain in through here. For those of you who are already hypermobile who do this, you might have to add a further strain by cranking your wrist down. The principle there, though, is that these are things that we all have. They can be made worse by prior injuries, by bruising around the nerve bed, so you might get an adhesion that stops that nerve from gliding. The nerve might be a bit swollen by a variety of processes. And if this is accumulating over a lifespan, then it may increase your risk for other problems. Well, let me move from that as an introductory session on what we're talking about with adverse tension and neuromuscular strain and neurodynamics to a paper that we published earlier this year that tried to formalize the observations we'd made clinically, that patients had these an abnormal degree of range of motion of the limbs and spine, and what we were the team that I worked with included Rick Violand, Kevin Fontaine, who's also a collaborator on the Solve CFS Initiative project, Colleen Martin, who's the mother of one of my patients in the clinic and who has volunteered for the past 6 years now, several hours a week helping me out with data entry and analysis, and has been tremendously helpful to getting our research program back up and running. And then the others on the list are students who worked with me in the summer, some of whom have gone on to graduate from medical school by now. Dr. Fontaine is now down at the University of Alabama School of Public Health, so we did this study looking at the issue of the range of motion impairments, thinking that because they can, people can get a worsening of their symptoms for a couple of days after their PT assessment, we were looking to see if these problems were present and part of the generation of symptoms in those with CFS. And the other thing that prompted us to do the study was this notion of the improvement over time once they started to be treated and the better tolerance of exercise. So this was a study drawn from clinical observations and meant to look at very practical things that might be useful in a treatment setting. So our study hypotheses were that compared to healthy controls, the adolescents and young adults that we were seeing with CFS would have an increased prevalence of these restrictions in symptom-free range of motion of the limbs and spine, and an increased prevalence of symptoms that were provoked by the range of motion measurements. So to do this, we designed a matched case control study, and the participants were drawn from our 2-year cohort study that we were doing at Johns Hopkins, where we were seeing new patients with CFS, not really selected for any one reason or another, and they knew that by taking part in the study they'd be filling out questionnaires and doing a lot of more detailed measurements of range of motion. But they also knew that they were going to get clinical care for the next 2 years. So there was something in it for them, which I think is really an important part of any clinical research study we do. We then matched the chronic fatigue subjects to the healthy patients, but we were looking at range of motion, and we'd known from before that people with joint hypermobility are overrepresented among those with CFS. We found a 3-fold increase in the risk of hypermobility if you've got CFS. So, you know, if you measure a hypermobile person against a stiff person, you're going to find that the hypermobile people have better range of motion. So we needed to make sure we were comparing apples to apples. So we found a group of healthy people who were as hypermobile at baseline as the CFS patients. And so that was what we matched on, was their degree of hypermobility using a thing called the Beighton score. And we also matched on the basis of sex because females are always more flexible than males. The main thing we were looking at was these range of motion measures. I'll just mention before I get to that, though, that these were people between 10 and 23 years of age. They had to meet the Fukuda criteria for CFS, and we excluded people because we didn't want a muddied clinical picture of people with CFS. We excluded those who had prior depression or who had been referred by psychiatrists, thinking that those who had been referred by psychiatrists probably had more complicated behavioral health or mental health issues. The controls were kids who were otherwise healthy, and we deliberately recruited people who were going to be as hypermobile as their CFS patients. So we tried to get more dancers and gymnasts and swimmers in the control population. We excluded the controls if they had other reasons for having fatigue. And for both groups, we wanted to be very careful that we didn't have anything else that would interfere with their range of motion measurements, like prior recent fractures, deformities or abnormalities of the spine, spine surgery, any kind of treatment from a physical therapist or a chiropractor or an osteopath in the preceding 6 months. So in other words, we wanted to get them before they started into treatment, and they couldn't have obvious things that would interfere with their range of motion. So on to this issue, we looked at several kinds of range of motion measurement, and I'll show you pictures of each of these. One was the seated slump test, ankle dorsiflexion that you've seen, passive straight leg raise, the upper limb neurodynamic test, and prone knee bend. And on each of these 5, you'd get a point for abnormal range of motion, which we defined before the study began, on each side of the body. So these 5 tests gave you up to 10 points of abnormality. The prone press-up was measured as either normal or mild, moderate, or severely impaired mobility. Here's the ankle dorsiflexion test, the prone knee bend, and we measured all of this carefully with goniometers and 2 observers. Here's the seated slump test, and this is an interesting one that's been developed in the physical therapy world, much of the work being done by Australian physical therapists, and I'm not sure who gets credit for doing this initially, but a lot of it has been popularized by Robert Elvey, David Butler, and others. And this is a test where the person sits on the edge of the table, as you can see in this upper left panel, slumps their back and puts the neck forward. And then the main test is the extension of the leg. And what this is doing, remember we said earlier that full forward flexion really takes a lot of the slack out of the nervous system. Well, this is a way of replicating that. And the therapist then has the person report what symptoms they have. The normal response is a stretch in the leg. And if you try this at home later, most of us will get a bit of hamstring pulling, or what we were told was hamstring pulling by our elementary school gym teacher. But what this test helps you do is it has a maneuver that's shown here where once you've recorded the symptoms, you bring the neck back up to the neutral position. And if the stretch or strain that you're feeling improves, then that's occurred while the hamstring length hasn't changed. So it has to be then have a neural component to the stretch, because what you've done by lifting your neck up is you fed some slack into a tight nervous system. And it's redistributed and reduced the tension in this area, we think. So that's the slump test. This is the passive straight leg raise, and you'll notice this is a picture of Rick Violand, and he's monitoring with his hand whether the thigh muscles are, whether the quadriceps are tightening. When the nerve gets to the point where it's stretched or about to provoke stretch, the muscles around that nerve tend to reflexively tense up and guard. And this is part of what we think creates an abnormal amount of difficulty with certain movements each day. Is if the nerve is tight, the muscles are also contracted and you're working against yourself with daily motions. The upper limb neurodynamic test is a way of putting
Unmuted.
median nerve, much like the pictures I showed you earlier, but this is done with the patient lying flat. There's a bit of strain put on the wrist. The arm is taken back and then fully extended, as you can see here at the bottom. And this is just the prone press up, where you're looking at whether the back has a nice normal curvature and the bend is equally distributed across the vertebral segments. So we recruited 55 patients who met our study entrance criteria. We recruited a larger number of controls because we knew we wouldn't have perfect matching. And of them, from that group, we were able to find 48 pairs where there was good matching by sex and by the Beighton score hypermobility category. And for methodologic purposes, we felt that it was really important that the matching be done by somebody who didn't know any of the patients or any of the controls, and so had no idea who had what in the way of movement restriction. And so that was one of our summer research students who did that work. The main findings are here, and this is a busy slide, so I want to break it down a bit. Let's look first at the left-hand side, the individual exam maneuvers. So on that slump test where you're seated and you're bringing your leg up, most people can get their leg to between 170 and 180 degrees. We defined abnormal before the study began as a less than 170 degree leg extension. So you get a point for your range of motion score if you couldn't get past 170 on either the left or the right leg. Same kind of thing, left and right scores for reduced ankle dorsiflexion. Straight leg raise, we defined normal as being at least 45 degrees of straight leg raise before you felt stretch in the back of your leg. And with upper limb neural tension, it was if the abnormal degree was less than 170 degrees of full arm extension, prone knee bend less than 130 degrees, and prone press up, as I mentioned, we graded in a more qualitative scale. So if you just look at the CFS patients versus the controls on all of these items, in every single case, the CFS group were tighter. They had more, a higher proportion of abnormal results on each exam maneuver. So 13 versus 8, 10 versus 2, 15 or 13% versus 0. Close to 70% with straight leg raise abnormalities or upper limb neural tension test abnormalities. 52 versus 17 on the prone press up. So if this was just a chance occurrence, we should have seen at least a few of these maneuvers being higher in the controls. That is that the controls should have had a few more areas of abnormality. But it was all higher in the CFS patients. And the next slide shows the ones that were statistically significantly different. These are the group proportions that were abnormal. The matched odds ratio is calculated a bit differently. It really looks not at the ones where cases were normal and controls were normal, but at the ones where the CFS cases were abnormal and the controls were normal. So that's a different statistical test. In the end, it comes up with an odds ratio of how many times, what the odds were that the CFS patients were more likely to have the problem. And you can see that these are pretty substantial and very highly significant statistically. If we graph that out, as you can see here, the control patients weren't free of range of motion problems, right? The score could go from 0, meaning no restrictions in movement, up to 11, which was every area was restricted. The controls had, a couple of areas with tightness, but you can see that the CFS patients in this purple color were shifted more towards the tighter end of the spectrum. And when you looked at their median range of motion score, that was, the median was 5 for our CFS patients and just 2 in the controls, and that was highly statistically significant. The other way we looked at it was that patients who had CFS had a 6-fold higher odds of having more than 3 areas of impaired range of motion. So that odds ratio was 6, and that too was significant. So our the one sort of simple way of looking at this, and the criticism we wanted to anticipate, was people were going to say, well, gosh, these guys are, a lot of them not very active. They aren't able to exercise well by definition, and they get post-exertional worsening. So their range of motion should be lower because they're just inactive, right? Isn't that the simple answer to this? So we looked carefully at activity levels. Actually, before I get to that, they also had more abnormal symptomatic responses to the test, just like we've been seeing in our clinical care. So 40% of the CFS patients versus 4% of the controls, and more of them had an aggravation of fatigue after the range of motion exam. We weren't doing it quite as extensively as the physical therapists do. The whole thing took maybe 15 minutes, and it wasn't a sustained stress, but we still cranked up fatigue and other symptoms. So back to the activity issue, we divided people into those who had not too many restrictions in movement and those who had 4 or more. And we measured their SF-36 physical function, which looks at how much activity can you do. And the scores did not differ between these two groups, nor did they differ on their vitality score. Higher scores are better, or on the functional disability inventory, where lower scores are better. This is a pediatric inventory that looks primarily at what activities are limited. So at least by this measure, which isn't the only measure we could have used, we probably, if we had it to do over again, we'd have actigraphy and other pedometer measures to look at activity. But I think this analysis shows you can't simply attribute the tightness that we were finding on the examination to their activity level. So in terms of conclusions, we think what this showed is that impaired range of motion is significantly more common in adolescents and young adults with CFS than in the healthy controls, provided you match them carefully by sex and by joint laxity. That, I think, is a critical methodologic issue. We think this showed that adding the elongation strain to the nerves and the soft tissues in those with CFS provoked symptoms in a subset, that the range of motions weren't easily explained by reductions in their overall activity. And taken together, those findings are novel. They're consistent with a reduction in the compliance, the sort of ability to accommodate in the neuromuscular system in this illness, and with the hypothesis that increased mechanical sensitivity of the muscles, the fascia, the nerves, and the connective tissues somehow contributes to the generation and the exacerbation of symptoms in the illness. Now, I do want to point out that the mechanisms for the impaired range of motion remain to be determined. We don't know in all instances what causes these neurodynamic dysfunctions, the adverse tension in the nervous system. But we're probably able to be neutral with regard to the causative hypotheses about the illness. So everybody knows that there are a group of clinicians who deal with CFS who think that really the biggest problem is that there's an infection or some kind of abnormal handling of a virus or bacteria. And so if they were to posit a reason for the adverse neural tension, they might say, gosh, this could be from the nerve edema caused by the infection that might be living in that nerve. Others have suggested the illness is perpetuated by immune abnormalities. And there are some studies now coming out of Australia showing that with nerve compression, you get a variety of immune changes in the nerve that could be akin to what we're seeing. In those with hypermobility of the joints, one of the problems is that they get into the head-forward posture a bit more. They're a bit more kyphotic. They have more lumbar lordosis, so they create a bit of an S-curve in their spine rather than a straight line. So that's going to create some loading and tensioning of the spinal cord and lead to some tightness, possibly even made worse by the fact that they can hyperextend their joints. So if you think back to the median nerve excursion picture, if their joint can go down another 20 degrees from horizontal, that nerve is going to be stretched that much more. And in addition to that, you could see anatomic problems, especially as people get older, with laxity of the ligaments in the spine, bulging discs, all of which could add to the deformative stress on the spinal cord in patients with the illness. The way we've thought about this, and this is something we published in a paper in Frontiers in Physiology, is that we all have some risk factors for neuromuscular strain because we've all had some kind of nerve and soft tissue and muscular injuries from twisting and turning and falling in childhood and probably accumulating throughout life. There are risk factors obviously for CFS, including gender, since we know that this is more common in females, the connective tissue laxity, and there are probably other medical conditions that contribute, but this isn't entirely well worked out. But you're bringing some risk factors from here, some sort of normal risk factors for neuromuscular strain from daily life. You then get the initiating event, whether it's trauma, infection, inflammation, dehydration, other acute stressors. Some people don't get an abrupt onset of their illness, so in them we'd think that these factors are just piling up over time. But once this occurs and you get a period of illness, then you're probably getting, for some reason, progression of the old movement restrictions or development of new ones in the nerves or the soft tissues. And you get increased mechanical tension within a system that we already know is less than fully compliant. So it's already a bit tight. And that by itself then adds to the amount of nervous system input to the spinal cord and brain that has a bit of a noxious effect. This can lead to inflammation and what's called central sensitivity, basically an over-responsiveness of the nerves to stimuli, physical, mechanical, and so on. And the clinical consequences may be the autonomic dysfunction we see, the nervous system sensitivity to a variety of stressors, and to the increased burden of symptoms. So once that happens, we can have maladaptive or adaptive responses. And by maladaptive, I don't mean to suggest that these are purposeful things that people do to make themselves sick. I just don't see that in my patients. But if you've got a severe illness that reduces your activity or a severe symptom burden that reduces your activity, we can assume that that will make you a bit tighter, that these nerve and muscle and soft tissue restrictions will worsen. And that, I think, is the central paradox of treating people with this illness, is we know they're intolerant of exercise, that too much exercise aggravates symptoms for several days. How do we get them out of that loop that is not really, in the end, good for them? The adaptive loop would be, we hypothesize that some therapies like manual physical therapy, Tai Chi, maybe gentle yoga, and some very well designed graded exercise might help improve these nerve, muscle, and soft tissue restrictions, leading to some improvement, rather than on this side, this vicious cycle where people get worse. Now, by manual therapy, I'll just mention a couple of things about that I've learned from my colleague. It really refers to the use of the hands to restore full symptom-free mobility between or in the neuromuscular system. And the goal of treatment is the same in the end as that of exercise-based PT, which is to get people to tolerate exercise. But the difference is that the manual practitioners first treat the areas of restricted movement before trying to push the person to more strenuous exercise. So they do a lot of hands-on treatment to improve range of motion, to improve muscle spasm, nerve glide, a variety of things. And these techniques can include stretches, passive oscillations, which are termed neural mobilizations, muscle energy techniques. There are other things like myofascial release, strain and counter-strain movements, and some osteopathic maneuvers like craniosacral therapy. And many of these techniques are drawn from the PT tradition, but many also from the osteopathic tradition. So our hypothesis is that something like manual physical therapy might be a good bridge between where people start off and where they need to be in tolerating exercise. So
Peter, we have about 5 minutes. So
I think we're good.
Okay, good.
So on the basis of a number of those observations, we applied to the Solve ME CFS initiative for a study to look at really replicating the straight leg raise testing I showed you, the 15-minute test. So we took healthy controls and we randomized them to a strain for 15 minutes, a straight leg raise strain, halfway between where they felt stretch coming on and where it actually was the end range of movement. So it was a mild stretch, not severe. And then the sham involved just leaving their leg on a towel raised about 5 degrees, not much of a strain. And we did the same thing with a larger group of people with CFS. And we're preparing that manuscript for publication, so we have to be a little bit careful about what we release early. So I can't say too much about the overall results, other than to suggest that they're very similar to what we saw in the young men earlier. And here's an example of one of the patients who underwent the strain maneuver. So before the 15 minutes of straight leg raise, here was the person's score on headache, achiness, lightheadedness, concentration, and headache. And 5 minutes in, you could see there's an increase in most of these symptoms, worse after 10 and worse after the 15 minutes. Then we put the leg down, but notice that some of them, while some of them had a slight improvement, they rebounded and had almost like the equivalent of a post-exertional malaise exacerbation 24 hours later. So this may be yet another way in which that central feature of the illness is provoked. The other thing that we noticed is that the people who come in sicker with scores of 7, 8, 9, we can't really demonstrate a whole lot of change if we're only using a 10-point scale. So methodologically, people have to be cognizant of that. I think you can see with the headache, a big increase in the headache symptoms that even persisted into the next day. So we're very intrigued by this. We think it offers both a physical examination abnormality that is evident and reproducible on the exam, and leads to some gentler forms of treatment that help people to benefit from exercise. Just wanted to mention a couple of the groups that have helped us with our work, including the grant from the organization. The Sunshine Natural Wellbeing Foundation has endowed a chair that allows me to continue my work at Hopkins. I mentioned Mrs. Martin, who's been tremendously helpful for our research, all the really excellent summer students we've been able to hire, and many of the patients who are really generous with their time and patient with completion of all the questionnaires we asked them to complete. And then we've been very lucky to have had donations from a number of families that have allowed us to do this work when, in some cases, like the paper I mentioned to you earlier and the study that Solve CFS has funded, where the NIH grant review process really didn't have much enthusiasm for what we thought was really interesting work. So thanks to the private philanthropy, we were able to get these studies done. We even had a couple of the patients do fundraisers. So we've been very fortunate with that kind of support. So I'm going to stop there, Suzanne, and see what sort of questions people have. Do you want me to switch control of the slides?
Oh, you can just keep them. So go ahead and flip down to the next slide, Peter.
Okay. Oh, right. This one. Yeah.
Yeah, so thank you very, very much, Peter. There's a lot of questions that we're not going to be able to get to, but what we will do is we will share these questions with Dr. Rowe, and he will answer them, and what we'll do is we'll put up, he'll work with Lee and I to put up another blog post as kind of a follow-up to this webinar. For sure, we're going to have, sign up and register for our webinar series. We announce them. You can register them. We make it really easy for you to participate. There's other ways that you can participate and learn about what's going on at the Solving CFS initiative by signing up for our Research First e-newsletter, following us on Facebook and liking us on Facebook. We push out a lot of good information about what's happening in research on our Facebook and website. Of course, you can be an active participant in the research process. Many of the subjects, patients, people that participated in Peter's research have also been given the opportunity to sign up for the biobank and do in fact participate in the biobank. And of course, all of this really cool stuff that you've seen requires money. So if you have the opportunity to, please go ahead to go to our solvecfs.org website and donate. So let me really quickly just get to a couple of questions that I think are really, really good questions.
Okay.
First of all, Peter, you alluded to this in that, is this just ordinary run-of-the-mill physical therapy, or is there a specific technique or approach that our CFS population community can tap into?
Yeah, so I think this requires a higher level of skill and training in these manual techniques. That's been pretty obvious to me. Just like not all physicians are practiced in the same way, it's the same with physical therapists, and you need people with training in these manual techniques and maneuvers. And it's not one type of manual therapy, it's usually an amalgamation of a variety of techniques. My colleagues who do this talk about finding a technique that works for that patient, for what that person is presenting with.
Okay. Will you and your colleagues be presenting these findings at like physical therapy conferences?
Yeah, we plan to. We've got a couple of follow-up studies that we are doing. One is the question of, well, what happens to these range of motion restrictions? Does the score change over time, or are they stuck that way? And so we've got a paper looking at the improvement in the range of motion scores over the 2 years that we followed them. And we're also looking at getting the paper out on the strain study soon, so that we get a few more people interested in this, which I think happened about 20 years ago when we published the initial work on the orthostatic intolerance. I'm hopeful we get that kind of interest and response to this work.
So are these range of motion restrictions that you've observed in CFS specific to CFS, or do they occur in other diseases like MS?
They probably do occur in other diseases because, as you saw from the one slide, we were finding them in totally healthy adolescents, right? It's just part of life that you get injuries and you get tightness and so on. So the real question is, what makes them so much more common in CFS? And they may be an underlying mechanism for fatigue across a variety of diagnoses, but they certainly seem highly prevalent and unusual in the CFS population.
So does that mean that there is some diagnostic utility to these range of motion issues?
I'm not sure if it's diagnostically helpful. I think it helps confirm to the patient. Often when they go in to see one of the physical therapists who sees all these areas twisted and malaligned and a lot of tension in the muscles and inadequate elongation of the nerves, when the therapist examines the patients, they often will say, gosh, you're a mess. You know, how are you functioning at all? And I think that's incredibly helpful to validate things, because often people will say, oh, your exam is fine. Well, it's not fine if you actually look at it carefully with the kinds of skills that a good physical therapist can bring to bear. So I think that it can be much more helpful therapeutically than as a diagnostic biomarker, for example, just because there may be a lot of overlap with other conditions.
So obviously there are patients, a lot of a range in the types of flexibilities that many of the CFS patients have. And in fact, we know that a lot of people were quite active and quite flexible, and they were dancers and experts in yoga, yet still they experienced these types of neuromuscular strain phenomena that you've described. How can we account for that? You know, having, for example, extreme flexibility or extreme athletic ability in dancing, for example, and yet still have these range of motion issues?
Yeah, no, it's a common question that we get, and part of it is that when you don't have a lot of good ligamentous support to the spine, so there's very strong ligaments that connect all the vertebrae, you can get this sort of increase in the kyphosis, the rounding in the back, and that lengthens the vertebral canal. So you have to have a lengthening of the canal's contents, so the spinal cord and so on. Then you see the nerve, the head forward posture that aggravates a certain amount of strain in the anterior part of the spinal, in the spine, and possibly puts some strain on the autonomic ganglia. And you know, those things may be part of why the hypermobile folks get into trouble, but they also have problems with too much movement of the vertebrae, and they get early disc degeneration. So their form of this might be different, but the ultimate pathway is probably similar. I'll give you an example of a really hypermobile girl in our study who was initially doing pretty well, but had a fall that resulted in instability in her cervical spine, and she suddenly had a marked deterioration in her overall ME/CFS symptoms. And so, you know, if you're hypermobile, you can sometimes have a worse result after a concussion or a fall than you might otherwise.
So in your experience with orthostatic intolerance, you would say estimate that maybe 60 to 75% of CFS patients have OI issues.
Well,
what are you estimating for?
Yeah, so I think in our studies, almost all the adults will have worse symptoms when we stand them up for 10 minutes, and certainly if we put them through a tilt test. So they might not all have hemodynamic abnormalities. We get about 60%, 60 to 65% who have either POTS or neurally mediated hypotension, but it's close to 100% who have worse symptoms with quiet upright posture. So I think we have to focus on symptoms as well as hemodynamics. With adolescents, the hemodynamic abnormalities are 95% or higher. Anyway, there was I think I interrupted you halfway through a question.
No. That got it. So Peter, we're going to wrap it up. We have the questions pouring in, but Lee and I will compile these, and we'll work with you to get these back to you and then addressed for everybody. I would like to thank everyone for hanging in with us for this very interesting and exciting webinar. And thank you. We look forward to your participation next time around.